thank the organizers of the National Stroke Conference, Pakistan, and also my good friend Dr. Vase for inviting me to give this talk. And I remember, I think in 2015, if I'm correct, I was there in Aga Khan University, Karachi, for 3 days for the National NCD program and also the stroke workshop. So what I'm going to do is talk about in a resource limited setting, how we can establish a stroke program and what are the models available in different countries. And so we all know the domains of stroke systems of care, starting from community education, raising public awareness. Then we have the primary prevention, the pre-hospital care, and then the acute stroke treatment, which is primarily in the stroke unit, and secondary prevention and stroke rehabilitation and community intervention. What about the pre-hospital care? There are many countries and LMICs, national ambulance services available. The 108 is in India in about 29 states, but there are many challenges. The first, and there are other countries like Pakistan, Brazil, Thailand, Iran, and China, where ambulance facilities are available, either a standalone government-run ambulance services or partnership with private NGOs or private organizations. But we have challenges. We all know about the traffic jams that we have in our countries. And even if the ambulance is dispatched, to reach the place and bring them back, we are going to lose precious time there. So in a situation like this, what happens to these patients? How do they come to us? So it's throughout most of the LMICs, it is by their own vehicle, or a very small proportion of them come by ambulance services. This is one of our studies way back in 2006. Only 12% of our patients reached the hospital by ambulance, and most of them came by their own personal vehicle. So what is the solution for LMICs in terms of pre-hospital care? If you're in a smaller city or a small town, probably you can create a own network of ambulance services. And however, in large metropolis, it is going to be very difficult. So it's better the patients and relatives reach on their own to the stroke center. So moving on to the next continuum of care is the stroke unit, care of stroke unit services. So what is a stroke unit? It is defined as an area within a hospital where stroke patients are managed by a coordinated multidisciplinary team, and they are specialized in stroke management. What is the population impact of a stroke unit? I think the slide is not moving, if I'm correct. And it is not changing there in the main screen. Okay, so I think I will just go slowly a little bit. And so what you see on the screen is the INSTRUCT study, where stroke care services in low and middle income countries, the outcome is poor, and they have less access to good quality stroke services. Then more of intracranial hemorrhage occurs in these countries. The next is the availability of personnel, particularly in Asia. There is one study which was published in Neurology India in 2016, where the ratio of neurologists to a 1 million population. I think the slide is not moving. Oh yeah, now it is there. So this slide shows the ratio of neurologists to population, the 1 million population, and you can see the highest is in Japan, and India and Pakistan, we are less than 1. So that is a disparity we have in terms of personnel to take care of stroke patient. In a situation like this, what we can do and how stroke units can be effective. So what happens in stroke unit? And there is a focused care of expertise. There's a team approach, and the early identification of factors that worsen the outcome. So you're able to pick up some of the complications very early, and you're able to implement secondary prevention strategies very early rehabilitation, and there is a involvement of the patients and families, and the entire team is motivated. So what is the evidence in terms of the stroke unit care versus medical ward treatment? This is a summary of Cochrane review, the latest one in 2020, where patients who are managed in stroke unit, they tend to be alive, living at home and independent, even at 1 year of follow-up. And this benefit is best in stroke units based in a dedicated stroke ward. So do we have data from LMICs? Are stroke units effective in less wealthy areas? Yes, we have data. There is a meta-analysis which we had published in 2012, where we compiled the studies where stroke unit patients versus patients were managed in medical ward, and there was a definite reduction in mortality, in the studies that were done in different LMICs. And so if stroke units are effective in terms of reduction in mortality, then because every LMIC is different and the healthcare system is different, and in a situation like this, what are the different models of stroke care that are available? So the one that we, in our own setup, we started way back in 2011, where there was a period where we did not have a stroke unit, and we compiled the data for the patients. Sorry. And then we, sorry. So then we implemented the stroke unit and collected the information, and there was reduction in complications, reduction in mortality, and there was increased access to rehabilitation services. But the length of hospital stay was slightly more because we had the in-hospital rehabilitation services. And as I mentioned earlier, that there is a shortage of neurologists in LMICs. In a situation like this, can we use the physicians to run stroke units, and particularly in district level hospitals? So this model we tested in one of our affiliated hospitals in northeast region of India, a place called Tezpur in Assam. So what we did was, before we implemented the stroke unit, we collected the baseline information, the demography, the stroke characteristics, then the complications, then some of the key performance indicators, and also 1 month outcome. And after that, we implemented the stroke unit. And before that, we identified a dedicated area in their hospital with 6 beds. And the nurses, the doctors, the therapists were trained, and there was an online training program. It took about a month for us to train them. And then they started admitting these patients in this unit, and they had an in-hospital CT scanner. This region, there are no neurologists. So what did we find? So there was a reduction in the complication rate as compared to the pre-stroke unit period. In the post-stroke unit period, there was a reduction in complication. But in the second table, if you look at in the left side, it is the key performance indicators are listed, where swallowing assessment, mobility assessment, then initiation of secondary prevention strategies, and at the time of discharge, the checklist for the medication. So all these things improved in the post-stroke unit period. And there was a reduction in the length of hospital stay. However, the outcome was similar in both the groups. There are a few reasons, but this study was designed to find out whether there is improvement in key performance indicators in a physician-run model. So then there is we also looked at another model in our own setup using the community health workers. In India, we call them as ASHAs. So we had a catchment area where there was a population-based stroke registry that was happening in 146 villages in the district of Ludhiana. And the ASHAs, the frontline health workers, were trained to identify stroke patients in the villages and report to us. And this program was integrated with the 108, the government-run ambulance services. If they were able to identify stroke patients, they were supposed to call the 108 ambulance or us, and then the pathway is integrated to the government stroke unit that we established in the district hospital, and also to us. And this is a Punjabi version of FAST, which we displayed as a flex board in the Sikh Gurdwaras and some of the prominent village areas where the people used to meet. And so we created awareness about stroke for almost 6 months and trained the ASHA workers, and then we started the project. And slowly we involved the entire state government. We trained the nurses, doctors, and the therapists. And some of us, we went to the district hospitals and also the medical college government hospitals. We trained them. We also had mock drills by which we were able to see how they are performing, particularly when a patient comes to them, how quickly they are able to identify stroke patients in the setup. So the features of Punjab state government program is it is physician-based, and the district hospitals have stroke units. TPA is available free of cost, and this is integrated with 108 ambulance service, which is again a government-run program. We were able to collect good data. This is a one-year data. All the centers were able to see in the state about 1,500 odd stroke patients, and about 5% of the patients came within 4.5 hours, and they were able to give TPA in about 3.6% of the patients. So there is some lag. So I think, okay, yeah. So there is another program in Himachal Pradesh, which is in the Himalayas. Again, there is a hub and spoke model. The hubs are the 2 medical college government hospitals. The spokes are the district government hospitals. They were also able to start stroke units and run the thrombolysis program. So across like India and South and Africa, we had a program called Organized Stroke Care Services across the income levels called OSCAIL, where in Africa, South Africa, Uganda, and Rwanda, and India, and 2 other centers, we did this project. And this is a global collaborative group with PHRI, McMaster University, Canada, and also University of Glasgow. So what we did was a similar design, before and after design. Before we implemented the stroke unit care, we collected the baseline data in all these hospitals. And then there was a face-to-face training, and we provided educational materials which was customized to their centers, but some of the modules were common for all these countries, and they were advised to modify according to the local situations. So this is a typical stepwise design where collect the data and before the pre-intervention, then post-intervention, and then collect the data. And we focused on key performance indicators like what we did in the center in Tezpur, looking at the stroke, the nurse-driven care, protocol-driven care, and complications, and secondary prevention strategies and rehabilitation. So this is the forest plot for the India sites, the two sites that we did in India, which shows there is improvement in swallow assessment, mobility training, secondary prevention strategies, and survival. To some extent, there is some improvement. This, again, the study was not designed to look at outcome. You need a larger sample size, but at least the key performance indicators, we were able to show that there is improvement. And then another center from, two centers from Rwanda, they also use a similar pre-intervention and post-intervention. And these are the two hospitals. And again, they also had the training program. And after the training program, the stroke unit care and the protocols were implemented, and they collected the data. And the preliminary results, this is not a published data, but they had given me the slides to share. There is some baseline difference in terms of there was more hemorrhage in the post-intervention period in this particular, in these two sites. And then the onset to arrival, it reduced from 4 days to 1 day in the post-intervention phase in these sites. Then the imaging rate increased in the post-intervention phase. Then the use of antithrombotics improved, use of DVT prevention improved. Then the swallowing screen also improved in the post-stroke intervention phase. The next is the mobility, then the blood glucose assessment, MDT meetings. There was some reduction in mortality in this cohort. So in summary, that there are models of care available in LMICs. This is one of the papers that we published recently in Lancet. Number one, in the typical advanced stroke care tertiary referral hospital, neurologist who is interested in stroke and with a multidisciplinary team. The second is a specialized led stroke care where neurologist is available, but he may not be fully interested in stroke, but still offer service. But there could be MDT or may not be MDT. And the physician-led care, the hub and spoke model, and the task sharing, that is the ASHA model, the community health model, which I just mentioned. So how to organize a stroke unit? I'll just quickly summarize some of the tips for people who are interested to start stroke programs. So the most important thing is to have a dedicated area, identify an area in your hospital, depending upon the volume of patients, start with 3 beds or 6 beds, have some monitors or infusion pumps, and identify the staff, the doctors, nurses. If you don't have a physiotherapist, try to use a nurse to do some of the physiotherapy work, and also the caregivers you can train. And this is one of the papers that we had published in Lancet, where you prepare protocols, you combine the MDT meeting along with the ward rounds. Everybody's busy, so many patients that we need to take care. So you can involve the nurses, you can bring in the therapist in the ward round and ask the progress about the patient, involve the family caregivers, and have a proper discharge planning. So we will run the stroke unit. It's again who's a champion locally. It could be a neurologist or a physician, and whichever who is the leader, and he can run the stroke unit. So I'll just skip maybe quickly. I'll talk about how through WHO, Southeast Asian Regional Office, we are able to improve stroke care in 4 countries currently: Bhutan, Maldives, Myanmar, and Timor Leste. From our team, we are training these people in these centers, and they were able to establish stroke services. And now we are moving on to stroke registry for stroke surveillance in these countries. So Dr. Ashfaq was mentioning about we need to have our own trial group to identify and find solutions to our problem. This is one endeavor supported by Indian Council of Medical Research, about 31 stroke centers in our country. And we in the network, it is only for doing stroke clinical trials relevant to our country and fully funded by Indian Council of Medical Research. Currently, 2 trials are ongoing. 4 more trials have been funded by the Indian Council of Medical Research, which will begin next year, most probably by March. So it is very, very important that capacity building also need to happen in the countries, particularly in LMICs, where we can answer our own problems. So in conclusions, stroke care models are available in low resource settings. Stroke unit is essential for acute management. Early identification of factors that worsened secondary neuronal injury is very, very important. Simple nurse-driven protocols can improve stroke outcome. Thank you very much.
Jeyraj, how many stroke units in India are in practice, which are run by physicians, like in the district hospitals or other hospitals? And what we can learn from their experience in the real world setting?
Yeah. So currently we have 5 states where there is active physician-led model. Himachal Pradesh, Punjab, then Kerala in South India. Then we have Maharashtra. It's not full-fledged, maybe 3 or 4 hospitals. So I would say total in about 5 states, and we would have at least 30 stroke units run by physicians in government hospitals. But there are many private hospitals where physicians are running the stroke program, particularly in South India, and slowly it is picking up in Northeast India. So in that way, people are gaining more confidence. That physicians are very good in giving streptokinase for acute MI, and we need to really, the LMICs like both countries, we need to really empower them. And bring in the government. So one fear is, for neurologists is, and also legally, if something goes wrong, if they traumatize, who's liable? So that is where, you need to have a good structured training program and work with the government. In that way, they are all protected. And the way it is functioning is there is a WhatsApp group in all these states where there is a neurologist, 2 or 3 neurologists who try to help them. Difficult cases, quickly the decisions taken to give TPA or not to give TPA.
So very nice talk. Just need to know what, as we are also same part of the world, and what possible collaborative efforts on the basis of the experience you already did, because almost same situation here in Pakistan. So they instead of inventing wheel, what possible calibrate effort in terms of a community level stroke care, and also the other those part where even not the neurologists are present, we can do in Pakistan keeping in view the experience which you had already done in your those part where neurologists are not available, even the low number of the neurologists are available?
I think the physician model is the best way to move forward. And the way from Indian Stroke Association and some of us, we owned the program. Like in Punjab, Dr. Jeyraj and me, we owned the program. Dr. Jeyraj is doing it in the neighboring state in Haryana. So we train them and identify a person and identify a few beds and identify the hospital first, identify a few beds, talk to the administrators, and try to help them. And another initiative which really helped us is Angels program, Angels initiative. What they have done is they go to the state government. None of us have time to go and meet the government representatives, but they do that themselves and then bring us into the picture, bring us into the discussion. So a top-down approach. So when it comes from the government, I think Pakistan, it is a province, if it is correct. The provincial administration, if they agree, you can select few, one or two hospitals and pilot test and see how it runs, and then you can expand it.